And we're live. What is neuropsychology? What are the long-term effects of head injury? Well, truthfully, I know a little bit about some of these things, and there's a lot that I don't know. But I'm joined today by Dr. Amanda Sachs Zimmerman, who is a professional neuropsychologist. Together, we're going to dive into all kinds of stuff like the long-term effects of head injury, how a neuropsychologist helps patients moving forward in the aftermath of these types of injuries and other things. So stay with us throughout the broadcast. We're really excited to have you all here today. We're going to get into all of that. But before we do, I want you to go ahead, head over to our YouTube channel. I want you to hit that subscribe button for us. If you are a real enthusiastic supporter of what we're doing, you can go ahead and hit that join button, become a super subscriber for $4.99 a month. We are a nonprofit organization. We are steadfast in our commitment to never paywall any educational content. So everything we do will always be accessible and free. We rely on the support of our community. So if you want to support us, you can become a super subscriber. We would greatly appreciate that. And so with that, let's go ahead and get right into things. I'm going to go ahead and bring in Dr. Sachs Zimmerman. Welcome, Dr. Sachs. How are you today?
Good. Thank you for having me.
Oh, it's my sincere pleasure. My sincere pleasure. So obviously the topic of the show for today is to get into what it is that a neuropsychologist does and how they help patients with traumatic brain injury. But, there's obviously a lot more to it than just diving straight into that. So why don't we start with just real simply, what is a neuropsychologist? I think there's a lot of people out there watching that frankly don't even truly know what a neuropsychologist is and what it is that they do.
I appreciate that question. My own family members say, are you a neuroscientist or a neuropsychologist? What is that? So, a neuropsychologist is a subspecialty of clinical psychology where we really focus on the cognitive functioning of an individual. So while we certainly consider the affective components of an individual, like mood, depression, anxiety, we're really primarily focused on what are the manifestations of cognitive functioning. So in that way, we focus on brain-behavior relationships. So if there's a pathology in the brain, whether or not it's due to, you name it, a tumor resection, epilepsy, colloid cyst, traumatic brain injury, we are interested in how that manifests on our measures of cognition. Does it alter someone's capacity for memory, attention, language? And of course, we consider the affective components like mood and depression, anxiety in terms of how it affects cognition, but we're primarily interested in creating a cognitive profile of an individual. With the function in terms of neurosurgery, does that impact a neurosurgical decision? Does that impact the way we would engage someone in interventional treatment for neuropsychology? Should we focus more on rehabilitating someone's attention versus memory? And really so we're implanted in neurosurgical departments, neurology departments, rehab medicine, because our specialty is creating that bridge between here's what someone's diagnosis is, but here's how it manifests in terms of their cognitive profile and the implications for their functioning. And that's where we can sort of draw that bridge and help decision-making in terms of neurosurgery and also help decision-making in terms of treatment options.
Wow.
It's a long drawn out explanation, but.
So I know you personally, from getting to know you in preparation for doing this show, you personally work more in an outpatient environment, correct?
Yes.
And being attached to Department of Neurosurgery, you're primarily working in sort of rehabilitation after, deficits following neurosurgical intervention.
Correct.
So what that means, obviously, so we have, a broad audience of people that are healthcare providers, people who are not healthcare providers. I think the important thing to realize here is that, unfortunately, not every patient that needs neurosurgery is able to come out of neurosurgery cognitively exactly the same when they went in. That would be a beautiful world. I think a beautiful world where a patient who goes into a neurosurgical operating room always comes out exactly the same in terms of who they are and their ability to think and feel. That would be a wonderful world. Unfortunately, we're not there. And so Dr. Sachs' job in the capacity that she personally works is in helping patients in some ways heal and recover, and other ways adapt and overcome sort of the deficits left behind. Is that a fair sort of way to kind of summarize what it is that you do?
That's absolutely fair. Yes. I mean, I would say that the primary reason I was hired was more so than assessment. It was really to sort of have individuals become aware of some of the deficits, but also be able to have them accept and derive compensatory strategies to live even optimally with some accommodations in the context of those deficits. So absolutely.
So what other types of environments would other neuropsychologists work in? Obviously, we've kind of talked more about your specific environment. What other types of areas do neuropsychologists work in?
So neuropsychologists are useful in so many different settings, from inpatient to outpatient in a variety of different departments. So there are neuropsychologists who work on inpatient traumatic brain injuries, step-down units where people are really more acute post-injury, where they're really focused on assessment with the idea of helping the rehabilitation team target their goals for PT, OT, speech and language therapy, to really outpatient treatment, where once the patient has gone through that acute treatment, what's next? What are the ways that people really engage in optimal outpatient functioning, whether or not it's neurosurgically based reason that they're in the hospital, or they've had an emergent issue such as a traumatic brain injury. We're really there to help assess, so really have a narrative around cognitive functioning and create a treatment plan, based treatment plan to help individuals optimize functioning after a brain injury. And in some ways, we conceptualize neurosurgery as a brain injury, not necessarily the neurosurgery itself, but the neurosurgical diagnosis that brought them in to have neurosurgery is akin to a traumatic brain injury. So how can neuropsychologists, in the continuity of care, help an individual basically reintegrate into life? And again, we're useful, and I'm biased, obviously, but I think we're useful in doing that in an acute way, inpatient, and we're integrated into outpatient departments, most often rehabilitation departments, PM&R. So with PM&R departments, even after neurosurgery, after individuals have experienced an event, they'll go to PM&R departments. Outpatient neuropsychologists will both assess and treat, but we're also integrated into inpatient departments as well.
So just to clarify for those who don't know, when Dr. Sachs is referring to PM&R, that means physical medicine and rehabilitation, or sometimes shortened to physiatry. They work in various capacities to help patients, and they'll sort of subspecialize. Some will subspecialize in traumatic brain injury, some will subspecialize in spinal cord injury, but these are very much patients that require very complex multidisciplinary rehabilitation plans, or kind of what a physiatrist or a specialist of PM&R, physical medicine and rehabilitation, will do. So I'm just going to take a quick pause. We've got a question in the chat from John Kelly. It's not entirely related to the topic of conversation, but that's okay. This is an open conversation. We're going to go ahead, no matter what your questions are, go ahead, stick them in the chat. We're going to go ahead and answer them. He says, lit lasers, the newest, most used tool in neurosurgery today, ? It's new. I wouldn't say it's the most used tool in neurosurgery. I think, from my own perspective and experience, I would say that the really routine, day-to-day, most used thing in neurosurgery is probably something that is not cutting edge and new. Maybe, and again, I say maybe because this is not based on any sort of data of what's used most frequently day to day. But honestly, something as simple as like an EVD is probably one of the most commonly used tools day to day in neurosurgery. It's not the newest, it's not the fanciest, but in terms of just what gets used the most day to day, it probably has something along those lines to deal with CSF management. But thanks for the question, John. Anybody else with questions, go ahead, put them in the chat. As they come up, we'll go ahead and answer them. We welcome all questions, whether you're a healthcare provider, you're not a healthcare provider, questions about traumatic brain injury, neuropsychology, anything you want to say, just go ahead and throw it in the chat. On that note, can we go ahead and get emojis in the chat, either, some thumbs up, clapping hands, whatever makes you happy, just to show support for patients with traumatic brain injury and their caregivers, because we're here to support that community as we sort of have these professional discussions. So go ahead and stick that stuff in the chat for us. I got another question. Let's see here from Kyle Zappi. Welcome to the chat, Kyle. We appreciate you joining us today. So, will patients ever undergo preoperative neuropsychological evaluation prior to a high-risk procedure? I think that's a phenomenal question. I'll go ahead and turn that one over to you.
Yeah, that's a great question. I'm speaking from the perspective of someone who works at Weill Cornell, New York Presbyterian, so I can't speak overall, internationally wide, but absolutely. And again, I work in neurosurgery. So our role here in neurosurgery is to do pre-surgical assessments so that we understand what your cognitive functioning is going into neurosurgery, so that post-neurosurgery, see if there were changes, we could see if you maintained at your baseline. And again, that's really our focus in terms of understanding not only prognosis, but treatment options after neurosurgery. For example, if let's say someone goes into epilepsy resective surgery, tumor resective surgery, and there's a decrement from where they should be in terms of language or memory, we understand that that's likely going to be something that they come out of surgery with, but that then leads to a treatment plan in terms of addressing that issue post-surgically. And unfortunately, oftentimes by the time someone comes to neurosurgery, they've been living with some kind of lesion for quite a while, which is both good and bad. The brain has a creative way of sort of working around that neuroplasticity. So we'll often see that someone who's had a lesion, certainly something that causes epilepsy, has been there quite a while, and they're able to maintain optimal functioning, even pre-surgically. But again, our job is to see if there's any kind of changes that would indicate whether or not the surgical candidate, or if they go through surgery, we're able to then create a treatment plan that's custom on that individual's manifestation of cognitive deficits. So short answer is yes. People and individuals that come into neurosurgery undergo preoperative neuropsych assessment.
And then we'll talk about this more as the show goes on, but I think something that, audience members might be wondering or thinking about is when we refer to cognitive treatment plans, and maybe as we get on, we'll talk about maybe some specific examples of what something like that might look like, because as we're learning about these things, even for myself, right, I am not I've never really interfaced with neuropsychology before, albeit the extent of my career is not broad and all encompassing. I'm sure there's tons of experiences that I have yet to even, scratch the surface on. But frankly, I don't even really know much about what a neuropsychologist means when they're talking about a cognitive treatment plan. But I think there'll be a good spot to kind of talk about that a little bit later in the show. One last question I have kind of on this topic of what neuropsychologists do and, what your typical day looks like would be if I was a student or, whether college, high school, somebody who had not yet gone down a committed career path, and I thought I wanted to possibly become a neuropsychologist. What is the academic path to that type of career?
It's long. It's really a subspecialty of clinical psychology. So what you're dealing with as a college student is just the prospect of, one, getting into a PhD/PsyD program, And a lot of the graduate level programs do not specialize in neuropsychology. They're general practitioner, science practitioner models, where the idea is that you are flexible and open to the variety of paths that you could take in psychology. Once you're in a graduate program, some programs are better, I don't want to say better, but more equipped to fulfill a neuropsychology path than others. So that once you get into a program, the idea is really you are basically seeking out experiences that gear you toward being an expert in neuropsych. So that might mean that there's certainly every program has a class in neuroanatomy, but that's not enough. So once you get that basic neuroanatomy, you really have to tailor your training to seek out experiences that are in academic medical centers, such as Cornell, where you can work directly with a neuropsychologist, either in neurology, PM&R, as I mentioned, neurosurgery, which is more rare, in order to really gain the skills of a neuropsychologist. So it's almost like an apprenticeship model to really, truly be able to acquire the skills needed to be a neuropsychologist. That being said, there is a national organization that has basically created a criteria for qualifications to be board certified in neuropsychology. So essentially, you go through, once you're through graduate school, you go through a higher order process of becoming qualified to be a board certified neuropsychologist, which is very similar to the boards that someone goes through in residency to become a neurosurgeon or psychiatrist, where you're then given an exam that really does require knowledge in a subspecialty and presenting cases with the idea that you're understanding cases from a neuropsychological perspective. So it's a long road, it's a longer road than just becoming a psychologist, which is already a pretty long road. So that often involves postdoctoral training. Actually, it's required that you have 2 years postdoctoral training to become a board certified psychologist.
Wow. Do neuropsychologists prescribe in any capacity?
Absolutely not.
Okay.
It varies state by state, but that's not predicated on being a neuropsychologist. So in certain states where you get some accessibility issues, they are trying to have prescription privileges for psychologists, but that's not predicated on being a neuropsychologist. But 100% no, not in New York. We do not have.
I see. So that issue is more rooted in access to care, not so much clinical scope.
Correct.
That makes sense. I can understand how that could make a difference in different parts of the country. Obviously, both of us just coincidentally happen to be in the Northeast. We sort of do. It's very easy to forget the lack of resources in other areas of the country. Absolutely.
Yeah, and there are. So you imagine, neuropsychologists exist throughout the country, but where there are not many neuropsychologists, there's often neurologists who are doing cognitive testing that we do. There's OTs who are doing cognitive remediation that interventional neuropsychologists are doing in the Northeast. It's sort of a geographical dilemma.
Interesting. So I guess this is another question I hadn't really thought of, but where's the overlap, or where do you see common overlaps between what a neuropsychologist does and certain MD specialties like neurology, or probably not so much neurosurgery, but I could see neurology or psychiatry. Do you have in some areas overlap with these more traditional medical specialties?
We do, but we are trained in a fundamentally different way. We're trained in a more sort of neuroscience-based, theoretical way than a medical model. So we are trained to quantify cognitive functions and understand the dynamical relationships among them, as well as training in the mind-brain connection. So really learning how co-occurring low mood impact cognitive functioning, and a variety of different factors, including sleep, diet, mood, psychosocial stressors. So we're really trained to, if I were to make it simple, funnel all the things that someone is living with into result in their brain behavior relationship. So how does everything that a human being experiences end up built in their cognitive capacity? And I would say with specialties, psychiatry or neurology, they don't necessarily have that breadth of taking into consideration all those aspects of one individual that we do.
Fascinating. Fascinating. Well, this is great kind of hearing about sort of the professional scope, development of a neuropsychologist. And what I want to do now is sort of shift gears a little bit to sort of the role of neuropsychiatry specific to traumatic brain injury. But before we do that, I just want to go ahead and take a quick break and say, what we were saying at the beginning of the episode. Brain and Spine Group is a nonprofit organization that is committed to fostering education, facilitating research, and engaging with the public on how we can improve the future of brain and spine health. Our live stream is just one of many things that we do, and we're able to do it because of the support of our community. If you are enjoying the show, if you like the content that we produce on a regular basis, if you have excitement for the things that we're doing in the future as we grow our capacity in working with veteran communities and bolstering the support for research to help get new research projects funded, to stimulate new research projects coming out of Brain and Spine Group. If you're excited about those things, which we hope you are, and you'd be willing to support our organization, you can do that by heading over to our website, www.brainandspinegroup.org/support. There you can donate. All donations are tax deductible. We're a nonprofit organization, and that will help us really get all this exciting stuff that's coming in the future, help us just keep pushing forward and improving brain and spine health globally. So with that, I'm going to go ahead and bring Dr. Sachs back in as we get into traumatic brain injury and neuropsychology. One of the things that I didn't know that you taught me the other night is that the approach to how a neuropsychologist helps a patient is fundamentally different depending on whether you're dealing with mild traumatic brain injury, i.e. concussions, which is, sort of much more common, versus dealing with severe traumatic brain injury where the trauma is much more apparent. Sometimes it's layered with polytrauma, meaning you have trauma to other organ systems of the body, motor vehicle accidents, military penetrating injuries. All these things typically result in severe traumatic brain injury. So do you want to just talk a little bit about how a neuropsychologist interfaces or creates a care plan or assesses a patient differently, whether they have a mild traumatic brain injury versus severe traumatic brain injury?
So, part of it has to do with context. So with mild TBI, or what's otherwise known as concussion, we'll see patients on an outpatient basis. Why? Because in the context of a concussion, someone might go to the ED because they've hit their head, but they won't need any kind of invasive care, and they'll be sent home, but will still be symptomatic. So at that point, a neuropsychologist is going to see a concussed individual outpatient. And at that point, we understand from the literature that it's a transient cognitive picture. In other words, we expect that the individual will start to improve cognitively, even physiologically, in terms of headaches, which is a common symptom, photo and phonophobia, so really sensitivity to noise and light. They will start to improve, we expect, within 2 to 3 weeks, maybe a month. Where neuropsychologists come in on that level is the person has not returned to baseline within 2 to 3 months. We're then looking at who really does need more extensive treatment. And for those folks, we're really always considering pre-existing factors. In other words, does that person have a pre-existing psych history, substance abuse, sleep issues, even neuropsychological issues like ADHD or learning disorder that might perpetuate or contribute to exacerbation of those symptoms post-injury. And we
I was
take that
actually
into
reading a lot
consideration.
about how that's really seems to, is muddying the waters of how they approach this expanding research in CTE, chronic traumatic encephalopathy, which is, obviously very trendy. It's, a huge emphasis from the NFL and NFL retirees. They're very focused on it, so naturally it gets a lot of attention. But really, this idea of what we call in the medical community pre-morbid conditions, right? Basically means like what sort of things made up a patient's clinical profile before the injury even happened. That's what Dr. Sachs is talking about for anybody who might not quite understand that lingo.
Yeah.
It's actually a much more significant factor that's muddying the water of research far more than I realized.
Yeah, totally. In terms of just the sports literature, there's research to show, because if you think of the ways that neuropsychology has been involved in sports, we've now been implanted in certain sports teams where neuropsychologists assess before they're concussed, but because they're the neuropsychologist of a sports team, they have the privilege and luxury of testing individuals pre-concussion and then post-concussion. And what those neuropsychologists have found is that individuals who end up having these persistent, I'm talking about, have pre-injury psych scores that are quite elevated. In other words, they're more elevated in anxiety, somatic symptoms before they ever get injured, and then it creates a longer course of recovery. So that's sort of an interesting experimental way that neuropsychologists have insight into how those pre-existing factors contribute to prolonged symptoms, again, in the mild TBI world.
I'd be very curious about how, if you could look at that in the military community, because from my own personal experience, I know they do, I assume it falls in the realm of what you're referring to, pre-injury neurocognitive assessment. I think a lot of the tests that they did prior to deploying to Afghanistan, it was, I honestly forgot about it. We had a guest on a couple episodes ago who deployed with me, who sustained a blast injury. And, we were talking kind of about his experience. And he reminded me of a lot of the reaction time type testing that they did before we deployed. It sort of totally, evaded me in terms of remembering it, but it was a huge part of his recovery process of constantly having to repeat these tests. I'd be curious if, sort of like what you're saying, using the sports team as this kind of controlled population where you have pre-injury testing to compare to post-injury testing, could you even look at it among even smaller cohorts? I can think of an example. There was a blast that occurred in the Sangin district, so a little up north compared to where we normally were. And basically what happened was, if you can imagine, a flatbed truck was being offloaded by a forklift. It's a big, heavy piece of machinery. You've got to imagine like a forklift with a tire. It's like 6 feet tall. And as the bed of the truck is sort of laying this way, the forklift is coming in, picking things up off the truck like this. And there was a Marine that was sitting up against the side of the truck, and the forklift came in. It rolled over an IED. It blew the 6-foot tire off of the forklift. The tire hit one Marine, the Marine sitting against the truck, in the head. Myself and several other individuals were in various distances, I would say, within the 50-meter radius that, I guess, since this time, the DOD's come out and said anybody within a 50-meter radius of a blast should be evaluated. At this time, those standards didn't exist. This is like 2010. But even if you looked at that cohort of individuals, we'll say within a 50-meter radius of that individual blast incidence, how do post-blast neurocognitive assessments change compared to everyone's baseline, even just in terms of, now you've got a very concrete population, comorbid conditions, and blast distance from the blast. I think this would be like, you could take, if you took every blast incidence and the military, right? There's always an after action report. If you took every one of those blast incidences and looked at the neurocognitive profiles of service members, and it would give very interesting pockets of sort of like small case, I guess would be like a cross section, to sort of look at how these things change over time. I don't know, something to think about. The big part of Dr. Sachs, as I know, sure you're kind of learning what it is we do on this live stream, is taking the experience of our guests, taking the experience of, pretty much what we do, and sort of in real time, we like to brainstorm, like, where do we take the future of research? And this stimulates, because we have many students that volunteer with the organization. Many of them are very passionate about brain and spine care. They're looking for novel research ideas. And so this is how we sort of in real time, we'll kind of brainstorm some novel research ideas. So something like that could be very interesting.
Yeah, for sure.
Anyway, I know I sort of interjected and we sort of went off on a little bit of a long tangent. We were talking about the interface or the sort of the dichotomy between mild traumatic brain injury and severe traumatic brain injury. Before we get back to that, though, might as well, rather than interrupt you again, why don't we look at a comment from John Kelly in the chat. He says, do neuropsychologists today value DTI, diffuse tensor imaging, being done? We didn't have this to use back in the Desert Shield storm era on the hospital ships. From what I can tell, I'll let Dr. Sachs answer this, but I'll give my 2 cents. From what I've read in a little bit of limited literature, is that obviously people are very hopeful for a spectrum of imaging to help bring a better understanding of the actual biologic changes happening in neural circuitry following traumatic brain injury, but very few things are known concretely at this point.
Yeah, I guess just in terms of the broad thought that comes to my mind when you bring up DTI is so much of my experience in outpatient concussion clinical treatment is that you'll often get people who are symptomatic, maybe 3 months post, maybe a year post, and whether or not it might not be DTI, but it might be some kind of neuroimaging, a CT scan, MRI, and there's no evidence of pathology. And assuming they get a DTI, there might not be evidence of pathology on a DTI either. So what do you do with that discrepancy with an individual who perceives and experiences symptoms that are impacting their functioning, and yet there's not that biometric that supports that? And I think that's the conundrum that as neuropsychologists, again, we need to kind of bridge that gap for the individual. That's really, truly, I believe, so much of our role is to explain away or to help an individual launch from a place of ambiguity, not knowing, that there's necessarily a biomarker to support that there was a concussive injury, but yet the perception and the impact on functioning is truly there, truly real, and yet we need to move the individual closer to where they want to be. So that's, I would say that that's the hard part of our job. But I would say to the question about DTI, there might be some value, but I would ask, what if there's a negative DTI? What if it doesn't show anything? And yet we know there was a concussive injury. We know the person is symptomatic 3 months, 6 months later. That metric has not much to do with the issue at hand in terms of helping the individual.
That was a great question. Thanks, John, in the chat for that. So I think, as you said, a big part of interfacing with a patient who's had a mild traumatic brain injury is about creating a plan to move forward. And I can imagine how there'd be a lot of ways that you could do that when you're dealing with a mild traumatic brain injury. Do you find when you're dealing with patients with severe traumatic brain injuries that have clear neurologic deficits, Do you find that you invest, I mean, obviously, I assume your effort with the patient is very different, but do you have a lot of interface and help that you provide to that person's caregiver or family?
Yeah, I mean, oftentimes, and again, if we're defining severe TBI or moderate TBI as needing some neurosurgical intervention, as you said, maybe multi-organ systems needed to be addressed, you're often going to find that someone's had multidisciplinary rehabilitation. So they've had speech, they've had OT, they've had PT, and they'll often get that on an inpatient and outpatient basis. Um, when I was working at Rusk, and I know they have this at Mount Sinai, there's intensive day treatment programs that really work on some of the cognitive manifestations of severe TBI, which from our perspective are really kind of frontal lobe based. So severe TBI, dealing with the most vulnerable part of the brain. It is a diffuse injury, but for the most part, the part of the brain that suffers is this sort of executive supervisory function that we have. And so the day treatments at Rusk, at Mount Sinai, are based in how to process information more effectively in a systematic. And the treatment can be, the program at Rusk is daily for about 6 weeks. So what I would say is for the more severe injuries, there's more intense treatment with the idea that you're perhaps not getting back to baseline after that treatment, but they make every effort to try to reintegrate the individual into some type of functioning. I know Rusk has a vocational training that happens after that day treatment program. So there's more intensive treatment after severe traumatic brain injury than there is after mild TBI. Again, with the idea that you're helping the individual adjust to more or less a new type of way that their brain is functioning, as opposed to the hope with MTBI, where we expect that an individual will at some point return to baseline.
Yeah, that's, it's severe traumatic brain injury it's such a challenging thing to even think about how to improve in the future, at least when I think about it as a provider, because sure, the best way to improve very severe TBI would be to just stop it from ever happening. And I think that's why we invest so much effort in the system of care in prevention over treatment, but you're never going to reduce that to zero. So should we be investing more research effort in, I guess, like biological care of traumatic brain injury, or should we be investing it more in the rehabilitative, cognitive, functional care? Obviously, it would be nice to do everything, but when you start thinking about what's showing the most promising impact on a research front, I mean, where do you see the most impact being made in terms of trying to find advancements? Is it on the biomedical side, or is it more in the cognitive rehab side?
I mean, I'm biased. I think
that's okay. We embrace bias around here.
Okay. I think investing in not only rehabilitation, but a sense of planning with rehabilitation. So I find what's often comforting for me as a neuropsychologist is to know that there's a bridge between what I'm doing on an hourly basis and real life actualization. So I think this idea of having vocational trials is truly important. And George Prigatano, who's a guru neuropsychologist at the Barrow Institute, really had that integrated into the Barrow Institute, where an individual is basically relegated from rehab right to something vocationally oriented. And when you think about the positive feedback someone can get from trying to engage in either baseline tasks or tasks that have meaning to them, we start to see that the brain meets that challenge and sort of takes care of the recovery thereafter. So I truly think investing in resources where we bring the individual from outpatient cognitive remediation treatment to more bridging the gap with what they're going to be doing in real life is so super essential with getting the individuals back to being citizens of society. In terms of like sort of more of the physiological, in terms of, I know some researchers were looking at bariatric oxygenated treatment for traumatic brain injury, in terms of really slowing down the edema and the swelling, with the idea that
like hyperbaric treatment.
Hyperbaric.
Yeah, I mean, we had, like I mentioned earlier, we had my buddy Mike, who I deployed with, had a really bad traumatic brain injury. He's tried all types of therapies and things like that, and he really spoke very highly about how he personally felt he responded with hyperbaric treatment. He's like, I can't really explain it, but it made me feel better, and I felt like it was helping me.
And I think there's certain efficacy to that. The question is, what's the mechanism of action?
Yeah.
I think if it's more oxygen to the brain, there's also research showing that exercise contributes to some effect of a protein in the brain that then enhances functioning.
Mm-hmm.
So, I think all these treatments are more or less experimental. You can really pinpoint the mechanism of action that you can then say, this is the treatment and this is the only treatment. Otherwise, sort of many roads to Rome, so to speak. But I mean, again, from my perspective, the idea is to really have a road for the individual that gets them back to some level where then again, there's more reinforcement, more of a sense that they can create efficacy and mastery for themselves, rather than just stay in the mode of, I'm not getting better and nothing's helping.
Yeah. And I'm sure that contributes significantly to addressing sort of the psychiatric outfall of traumatic brain injury. I'm sure there's a biological component that explains why incidence of depression and other psychiatric issues are higher in the setting of traumatic brain injury. But if you're not seeing that, or if you can't appreciate any sort of cognitive recovery, that will only exacerbate that sort of biological underpinning of depression. Absolutely.
Right.
All right. Well, what I want to get into next is a topic that came up in our sort of pre-stream conversation yesterday about the elusiveness of the diagnosis of a concussion. But before we do that, I'm going to go ahead and just pause for a moment. I want to welcome everybody into the chat. If you've come in since the beginning of this stream, I am joined here with Dr. Amanda Sack-Zimmerman, a professional neuropsychologist, and we are going through various different aspects from what a neuropsychologist does, how they help patients deal with long-term recovery of traumatic brain injury. Coming up next, we're going to be talking a little bit more about what the diagnosis of a concussion means. It's a very common phrase to thrown around both clinically and non-clinically, sort of by people out in the world who are not doctors, but even doctors and clinicians use the term. So it's a very common term that's very vague in what it truly means to people. And people have different definitions. So we're going to break that down next. But before we do, I just want to thank you all for tuning in. Now that we've kind of got anybody who came in midway caught up on where we're at, do me a favor. I want you to go head over to our YouTube channel, hit that subscribe button. We're getting close to 10,000 subscribers. We really appreciate everybody that's willing to, stay subscribed to our channel and watches our content. If you're a huge supporter of what we do as a non-profit organization, you become a super subscriber, a gold subscriber, by joining our community for $4.99 a month on YouTube. There's a little join button on our profile page. The benefits are that you get to support our nonprofit mission and keep us functioning. We are committed to never paywalling educational content so that it's always free and open to everyone, regardless of their means to support our organization. So in order to keep that way, we ask that those who are able to support our organization support us by becoming a super subscriber for $4.99 a month. You can do that right on our YouTube page. So after this little break, let's go ahead and get right back into sort of the next topic, which is something that Dr. Sachs brought up in our conversation that I never even really realized, is what is like what's the issue with diagnosing a concussion? Other than, I mean, clearly, I think you can kind of identify it. I say a concussion, I might not mean the same thing that you're referring to. How do you see that play out clinically among patients and different providers?
So, yeah, I mean, a concussion is something where an individual will experience an event, and then after the event, they're either brought to the ED or they bring themselves to medical attention. And it's really based on sort of their memory of the event. So, certainly there's a head injury. Um, but in terms of the actual definition of a concussion, which again is synonymous with mild TBI, although there's complicated concussion, which is another issue. But mild TBI slash concussion is this idea that there's not PTA, post traumatic amnesia. You kind of remember everything that occurred around the event. You didn't have a loss of consciousness, but you're symptomatic after. You know, you experience headaches, dizziness, sensitivity to light and sound, and you might be kind of off your game for a little while, attention, memory difficulties. What's interesting about a concussion is, and this has been sort of the work of some of the neurologists working on concussion, is there sort of a criteria, a physiological criteria for a concussion? Is there a certain amount of force, a certain amount of coup contra coup injury that is required to meet a diagnosed concussion? And that's really inconclusive. So you can have individuals who might have gotten hit on the head with like a cereal box, which doesn't create a lot of force, a lot of speed, and are symptomatic, truly symptomatic, versus, as Ryan, you were bringing up, our sports injuries, where truly individuals are getting hit to the ground at rapid speeds and a lot of force. So are those sort of equivalent in terms of their medical manifestations? And do we call both of those a concussion, even in kind of that same criteria of no post-traumatic amnesia, no loss of consciousness, yet the context of the injury is different? So, you know, I would say that a lot of the patients that might be walking into our outpatient clinic, into the ED, are really in the realm of where it's ambiguous. You know, was that enough of it to really cause a concussive injury? And I think that's ambiguous. So for the most part, we're going on behavioral description on the patient's part of what's considered a concussion and symptoms that they're presented with.
Great. Well, we've got a question in the chat that I'm going to bring up, and then we're going to get right back to this topic of the diagnosis of concussion. But thanks, Jackson G in the chat says, what age do neurosurgeons begin their work after residency and trauma subspecialty training? I am interested in this field of medicine. So if I'm understanding your question correctly, you're basically asking, at what age does a neurosurgeon typically get into the actual work field and they're no longer in training? That is probably, the answer to that question is probably a little bit scary if you are on the professional end wanting to go into this career field. It is probably a little bit relieving if you are a patient who needs a neurosurgeon. But typically, if you're really early, meaning right out of high school, you never take a year off and you go straight through, maybe 31, 32, you sort of hit the job market after, you're fully trained and you're ready to be a trauma neurosurgeon. But the reality is everybody comes into the field at various points of their career. And I know people that are finishing their training at 45, 46 years old. And for various reasons. Some of that are people, they did a full residency in another country and they've now immigrated to the United States and they want to be able to practice neurosurgery here in the United States, and they have to repeat their residency. And, that's generally the less common scenarios that land people in that older category for finishing residency. But at least that kind of gives you the left and right extremes, sort of how old someone is. As of there are subspecialty training in neurotrauma and critical care. It's a little bit on the newer side. For many, many years, a generally trained neurosurgeon was considered to be equipped to handle all neurotrauma, which surgically and baseline medicine, they absolutely are. But we are seeing that there is value to having a subspecialty trained in both neurocritical care, which is where, unfortunately, a significant part of neurotrauma, that care, when you're talking about the acute period, that care is happening in the ICU much more so than the operating room. There's plenty of surgeries that we do for neurotrauma, whether it's spine or whether it is the skull, the brain, but usually it's sort of surgery's done, and then it's really up to the ICU to get the patient through what comes after surgery. And so a big part of being a neurosurgical, neurocritical care trauma specialist is that ICU critical care component. So thanks for the question. Hopefully my answer was in-depth and detailed enough for you. And with that, let's go ahead and get right back into what we were talking about, this elusive diagnosis of concussion. So let me ask you a question, and this is really about, in many ways, my learning. Do you equate mild, well, actually, let me back up the train a little bit. When we're talking about traumatic brain injury, we typically put them in three buckets: mild, moderate, and severe. Obviously, nothing ever fits succinctly into three buckets. It's the human nature to want to categorize things like that. Do you consider concussion and mild traumatic brain injury synonymous terms? Or in your clinical definition, do you differentiate one versus the other? Oh, hang on. We may have lost the audio here. Did we lose your audio? Oh, that's strange. Okay, we're going to take a quick pause while we figure out why we have lost Dr. Sachs' audio. All right. It sounds like it's just a small technical issue that shouldn't be too hard to fix. We're just going to go ahead and reload Dr. Sachs' stream back into the chat. So if you don't mind hanging with us for a brief period of time, we'll be right back online. In the meantime, I'll go ahead and catch everybody up. If you've come into the chat to watch and you missed the beginning, we are currently going through the long-term effects of traumatic brain injury and sort of what a neuropsychologist does to help patients create treatment plans and paths forward in their life, which is a big theme of what the ultimate goal of a neuropsychologist is, which is really helping patients create a path forward. So let's go ahead and see if we can get Dr. Sachs back in here.
Am I on? Can you hear me?
Oh, I can hear you. There we go. I think we're back. We're good. Okay. Where do we leave off? We left off talking. I had just asked you a question. Do you remember the question?
yes, the elusive nature of concussion, and that's sort of in the bucket of mild, and then what happens in terms of diagnosing the more moderate brain injuries.
Yeah. Do you consider mild traumatic brain injury and concussion synonymous terms, or do you clinically differentiate the two of them in some way?
So, I mean, I'll talk about the way I was trained. Concussion was not thrown around so much in the early 2000s. You know, we called everything related to traumatic injury. So a mild TBI was where there was minimal loss of consciousness, no traumatic amnesia, and the individual was basically not hospitalized. There was no neuro findings. That would be considered a mild TBI. And so it seems like what leads to some ambiguity is concussive injuries in the general population. Let's say concussions that can occur in the more sports-related injuries where there might not be PTA, might not be LOC, but yet the person is quite
PTA being post-traumatic amnesia, or LOC meaning loss of consciousness. Just a little translation for the audience.
Right. So yes, I mean, to answer your question, a mild TBI and concussion are basically synonymous from where I'm coming from. There any surgical intervention, and basically was more or less returning to baseline within 2 to 3 weeks. And as I said, you know, individuals come to us when they really haven't returned to baseline in the expected time that a mild TBI/concussion should be returning to baseline.
No, I completely agree. I think my mental framework works with the definition of concussion and mild traumatic brain injury virtually interchangeable. So I think I see very eye to eye with you on that clinically. Now, in terms of like post-traumatic amnesia, I know that literature tells us that the degree of post-traumatic amnesia is pretty well correlated to severity of the injury and prognosis of cognitive recovery. And I think that's very logical. It's very easy to wrap our brains around that if you are, you know, have this long period, we don't remember anything that happened, that you likely had a very severe injury. And that if it was just this brief blip of a moment, that your injury is not necessarily so bad. Do you subscribe to the diagnostic criteria that if you have any amount of post-traumatic amnesia, you definitively have a concussion? Or can you see a clinical scenario in which maybe you have some post-traumatic amnesia, but not necessarily a concussion? And if you don't know the answer to that question, that's okay. I'm just curious. I'm kind of picking your brain at this point.
You know, I think in real, it's more complex than that. I feel like when you start to really interfere, which is what we do on an intake, they'll often, once you really ask pointed questions, they might say or anything, but when you start asking what's the first thing you remember with those questions, PTA amorphous. They do remember more than they might have otherwise thought they did. So there's like a bit of an evolution. You know, what I would say is I think past 30 minutes, like if a person really doesn't remember the entire day before, doesn't remember the entire day after, you're definitely dealing with like a more severe brain injury. But in that time period where it's more ambiguous, like they kind of remember people surrounding them, they kind of remember ambulance coming, they kind of in the ED. I don't know that that becomes a marker for severity because, again, this is sort of an evolved process. And with pointed questions, you might find that they're able to read than they otherwise are when you just ask them.
I see.
And again, I am biased because these individuals are coming wanting help. They're wanting help no matter the level of severity, no matter any of these sort of criteria that we're trying to fit them into. They want help because they feel different.
As in, like a patient comes in and they're like, I just feel off, or I kind of feel brain foggy, but they really can't describe problems that they're having,
Exactly.
like concrete problems. So what types of things can you do to help patients where that's sort of the bucket they fall into, right?
To them.
Nope, I think we're losing it through the Star
going in
Pavilion
and out,
stellar internet. What's that?
I could try to move. Can you hear me now?
It's a little delayed. I think the Star Pavilion's poor internet connection is striking back right now. We can see if we can get a slightly better connection. Maybe we'll get keep you from breaking up. But go ahead. I think the audio is okay right now.
Okay. Your question was. Repeat your question.
Oh, sure. So for these patients where, you really have trouble eliciting concrete problems that they're having. They tell you, my brain feels foggy. I feel off from this injury, but you can't get that like real intervention, like problem to intervene on out of them because they can't describe it. How do you help them with that? How do you approach that?
So, oftentimes I do like a brief neuropsych assessment just to determine if there are any issues that seem above and beyond what they should be experiencing. So, for example, they're impaired on memory or attention. It doesn't quite tell us if it's because of concussion, but it tells us that that's likely what's driving what they're describing. What I would say is try to bring in other factors that might be explaining some of the dysfunction. Is it environmental? Is it psychological? Is it sleep? Is it environment? Is it psychosocial stressors? We really a paradigm where we can see modifiable factors, because if we attribute all the way they might to it's unchangeable, can't do anything. If we say, look, this certainly might be an impact of a concussion, kind of do a little psychometric round. Likely, the concussion, if it's mild, you should be back to baseline. So we need to look at these other factors. Then it opens up the possibility for the patient. There might be other drivers of dysfunction, and that becomes very important, defining where we might target treatment.
And how successful do patients find a lot of success when they finally kind of get on board with that plan and say, okay, let's look at some other, areas of life? Do you find that tends to lead down a helpful path for patients?
I do, for the most part, because you can imagine someone who's, let's say, in their early 20s and have yet to really fully introspect on some of the factors be contributing to dysfunction. Again, not to say that the concussion isn't one of those drivers, but they maybe haven't looked at family dynamics. They maybe haven't looked at social anxiety. They maybe haven't looked at attention difficulties that have always existed. And here, someone in their 20s is placed in different environments that are new, that might be exacerbating that. So the concussion denominator explanation, they haven't truly fully flushed out those other elements. So the concussion almost becomes the catalyst to look at those things, see how they might be playing out in a very developing. And again, I think in my population of, let's say, mid-college to post-college, like I would say 20 to 27, you have a lot of undiscussed to turn.
Mm-hmm. So do you find that this is more a problem in that, 20 young adult demographic, or is it just manifests differently in young adults versus older adults or seniors with these types of injuries?
I mean, I certainly think when it comes to younger adults, so much in terms of what's going on that's not working through the concussion. And like I said, you're dealing with a 25-year-old who's had so many changes in a very short period and has never sat back to really look at all the ways that their psychosocial history has been contributing. For those individuals, I find that those connections can really open the channels of communication in ways that they've never been, and have novel ways of communicating about some of these pre-morbid can often create different paths for the treatment. Some of the older folks, certainly we're talking about persistent symptoms after which a concussion should not be implicated in terms of ongoing dysfunction. I would say we similarly look at all those other factors, but we also look at ways in which we say, look, how do we get you to where you want to be? And oftentimes it's breaking certain habits for quite a long that's created some of the dysfunction with. So for example, I have a concussion patient that I've recently seen. There's no doubt she's a kind of head injury. She was on a scooter. She was unconscious. She was D. She has memory surrounding the injury, but doesn't realize if she had lost consciousness. If you do a quick history, she basically has had variable employment, had psychosocial stressors in her mother who has dementia. She has properties in different countries she's been unable to manage for quite a while. So we factor in the concussion, all you have is a sense that exacerbated what was going on before.
I see.
So the work I do with her is really to try to the work I'm doing with her.
What was that last thing you said?
Strategies to help. What was that? I don't know.
So I think we're just getting a little lag in the
just with
communication. Can you just repeat the last piece that you said?
I can try to move to another room to see if that helps. Should I try to do that?
Sure, we could take a quick break as we're sort of getting to the end of this chapter of the show anyway. We're getting ready to go into our last chapter where we're going to kind of talk about chronic traumatic encephalopathy and your experience with that. So what we're going to do is, before we get into this last piece of the show, we're going to take a quick break and let Dr. Sachs try to get to a spot where her internet feed will hopefully be a little bit stronger for us, so that way we can have a little bit more of a dynamic conversation for all of you. For those of you who are coming in and have not been here the whole time, I'm Dr. Rad. I'm the head of Brain and Spine Group, a nonprofit organization. Our goal is to improve brain and spine health globally, and we do that through a number of things, primarily education, facilitating and empowering research for brain and spine illness and injury, and engaging with the public in a way that brings light to problems that affect patients and loved ones of patients with brain and spine injuries and illnesses. We thank you all for tuning in. Today's episode of Brain and Spine Group Live, we're discussing with Dr. Amanda Sachs Zimmerman, who is a neuropsychologist, her experience working with patients with brain injury specifically traumatic brain injury, and how a neuropsychologist interfaces differently with patients of mild traumatic brain injury and patients with severe, more serious traumatic brain injury, and how a neuropsychologist works with these different types of patients to create cognitive assessment and rehabilitation plans, which means how do they actually talk to a patient to evaluate the psychosocial stressors of their life, and how do they create intervenable, actionable plans to actually move forward in life. Because some things, sadly, at this stage of medicine, when you have a brain injury, you can't always just fix the problem. You can't always give medicine or do a surgery or, use a prosthetic device of some sort to just magically solve. Although I suppose if Elon Musk has his way, maybe there'll be implantable chips that would circumvent some issues of traumatic brain injury. But shy of that, right, there's not a whole lot in terms of what we can do to reverse the course of traumatic brain injury. And that's a big problem in this world, because traumatic brain injury affects many people. It's a very prevalent disease, not just in the United States, but globally, especially in countries that have very little infrastructure for preventative measures. And as we've said, preventing traumatic brain injury is the best treatment of traumatic brain injury. And so if you think about, countries around the world where they don't have measures in place for wearing helmets when they ride motorcycles, my goodness, we have enough traumatic brain injury from motorcycle crashes just in the United States, where helmets are largely mandated. Just imagine how many more there are throughout the world where things like that are largely optional, right? And so traumatic brain injury is a big problem. And as a nonprofit organization that has a special heart for injury and illness that affects veterans and military service members, traumatic brain injury is a big focus of what we're interested in. And so we are really all about creating ways that we can improve the world on the front of traumatic brain injury, being just one of the many reasons that we are avenues in which we approach improving brain and spine care around the world. And so before we get into the last section of the show, I just want to point you back over to our website, www.brainandspinegroup.org/support. If you would like to support the nonprofit organization, we are entirely volunteer run and operated. We rely on the support of our community in order to keep our technology and our infrastructure running so that we can continue to do seminars and live broadcasts and write research proposals and research papers and mentor students and engage with the public on a meaningful level. We can't do these things without your support. So go ahead and head on over to brainandspinegroup.org/support if you'd like to become a part of our community. We would love to have your support. So now we've got Dr. Sachs back in here. Hopefully some of these technical issues have been wrapped up. If not, we're going to persevere, because that's what we do. We adapt, we overcome, but we never give up. So let's go ahead and get into the last part of the show, talking about chronic traumatic encephalopathy, which is probably what a lot of our audience has come to hear about. It's very trendy. The NFL retiree, I'm assuming there's some sort of players union for retirees of the NFL. It's something they're very passionate and pushing focus on, which is how we change the world, right? We bring attention to problems, and that's how we address them. So now what we want to do is sort of dissect it a little bit. And hear from, Dr. Sachs's experience, what some of the current problems are with CTE. Rather than keep saying chronic traumatic encephalopathy, we'll just refer to it in the shorthand as CTE. I want to make sure we make what that abbreviation is very clear for anybody out in the audience who doesn't understand. CTE is chronic traumatic encephalopathy. So, Dr. Sachs, tell us a little bit, from your perspective and your angle of training, what CTE is, because some people probably don't even know. And that's okay. We're here to tell you.
So, I mean, again, we don't often see these patients, but we do see patients that have allostatic factors that contribute to various types of neurological conditions as they age. So we'll often see individuals with Parkinson's disease, Lewy bodies disease, Alzheimer's disease. And, from our perspective as neuropsychologists, we're not necessarily looking for what caused the cognitive issues we're seeing. We're just trying to put together pieces of a puzzle. So, we certainly often think about how the frequency of brain injuries that someone might have had, such that that adds to what we're seeing, let's say, of an aging individual. So again, we don't see CTE as course within our clinic, but we might see individuals who are here because they've now developed Parkinson's and do have a history of significant brain injuries throughout their life. And so we might be asking ourselves, did those brain injuries in terms of accumulation have an impact on what we're seeing now? And again, with CTE, it's hard to know because that's a diagnosis that's made post-mortem. In other words, after someone has passed away, they'll analyze brain tissue and really see whether or not there's certain proteins on brain tissue that point in the direction of what is the criteria for CTE. It's not really a diagnosis you can confirm 100% while someone is still living. I think the trouble that we have with CTE in general is that it overlaps with a lot of those other neurodegenerative conditions that I just mentioned. So this idea of short-term memory loss, confusion, impaired judgment, having anxiety, depression, that really does overlap with an individual who might have another type of neurodegenerative condition. So it's very hard to parse apart what's CTE versus Lewy bodies versus Alzheimer's disease. There's some sort of prototype symptoms that belong to each category, but it certainly wouldn't negate that someone has the contribution of head injury to what's going on as they age. So again, it's tough to diagnose. And again, from my perspective as a more interventional type of neuropsychologist, it doesn't quite matter, because if you're going to see me for treatment, we're going to work on functioning independent of the causality of the difficulty.
So I just want to go back to the part where you mentioned it's really CTE is truly a post-mortem diagnosis, because I think that's an important thing to understand of why it's so challenging. As you said, it's so challenging to really nail down such a diagnosis. And you might even raise the question of outside of a pathological specimen. When we say pathological specimen, that's why I brought this picture up, because I just want to show the audience sort of what Dr. Sachs is talking about when she's referring to a post-mortem or pathological diagnosis. This is just one of several frameworks in which we look at CTE. And this is just a brief example from an article that shows what specimen brain tissue looks like when it's evaluated post-mortem. Or in this case, what they're showing are samples of presumed CTE at different stages of development. Stage 1 being that's largely normal. They don't see anything grossly, which is the gross specimen. The big picture of what you see is on the left, and then the microscopic, what you see under a microscope, is on the right. You don't see much in stage 1 of the disease. Stage 2, you start to see what they call some subcortical hits on the gross specimen, these little punctate dots that you see lining the outside of the specimen. They're very surface level. They're basically just below the cortex, affecting those areas. And then as the disease progresses, you see how it becomes in stage 3 more widespread. And then in stage 4, you start to see it affect this sort of deeper, what we call mesotemporal region of the brain, and becomes more. And typically when you're talking about post-mortem CTE, generally what the only real evidence we have for this disease is basically looking at stage 4 specimens after someone has passed away. But you can imagine that you're not able to really well establish the stage 1 or 2 or 3 in a patient who's still alive, right? And so that's why we rely on how do they present clinically to try to triangulate symptoms that tell us this might be a picture of CTE. And you can even see by go to another figure here for you. Let's go here. This is just a brief outline of 1, 2, 3, 4, 5 different frameworks that have been proposed in the literature about the diagnosis of CTE. Some people, as this first paper breaks it into 4 different stages, and they give clinical definitions of what those different stages are. Another paper says that they break it into likelihood of it actually being CTE. And that's a testament to the fact of how little we really know definitively. Another paper just puts it in 2 different categories of behavioral and cognitive. And they basically say, well, we're not going to go on the probability. We're going to go based on more of the phenotype, where phenotype means sort of the physical display of things. We're going to sort of see, do they have more behavioral problems? Do they have more cognitive problems? And so the point of bringing this up is not to go through this point by point, but for the enthusiast out there who's not necessarily a neurologist or a neuropsychologist or somebody who deals with this professionally, to understand that when we talk about CTE in the news, there's a lot of unknown variables and uncertainty. And so it's a very difficult diagnosis for that reason. And when the diagnosis is difficult, the research becomes even more difficult, because now you don't know who we even need to study. It's a challenge. It really is. So on that note, why don't we talk a little bit about some of the diagnostic challenges of CTE and sort of pre-morbid conditions. We talked a little bit about this, that they actually, you said in athletes, they find there's actually a very high number of pre-morbid conditions, correct?
Right. I mean, like with any aging population, there's a lot of pre-morbid factors that you have to consider that might go into cognitive decline, including vascular conditions, cardiovascular conditions, the neurodegenerative conditions that might have happened idiopathically independent of head injury. So, yeah, there's a lot of factors to consider when diagnosing CTE.
Is it possible that CTE is more of an overarching umbrella of other that kind of catches many different types of neurodegeneration, and that maybe we traditionally have not ascribed to brain trauma? Because I know obviously there's a lot of discussion about Muhammad Ali developing Parkinson's disease? Is that related to repeated head blows and sort of falling under the blanket or the umbrella of CTE? I mean, is it possible that we kind of realize like a lot of the neurodegeneration falls under the blanket of the umbrella? I don't know why I keep saying blanket. Falling under the umbrella of CTE?
I mean, it's quite possible. I know right back in the day, there was like dementia pugilista or something to describe some of the...
Yeah, that's what they used to call it. Yeah, dementia pugilista.
So certainly, look, I mean, I think as neuroimaging and our ability to really have functional ways of seeing the brain has changed, that's where you see the advent of some of these diagnostic categories like CTE, where you're really able to create a pathology and be more specific in how it manifests, like the idea of Lewy bodies versus CTE. So tauopathies versus neurofibrillary tangles, I think all of that has led to more specificity. That being said, I don't know that considers all of the factors that create the manifestation of these disorders. There's certainly genetics that goes into play. So does the APOE4 factor, does that factor into why one professional football player is going to manifest with CTE versus another? Does an NFL retiree that gets Alzheimer's disease get sort of captured under CTE as opposed to Alzheimer's disease just because of their history? It's really hard to know how we're putting all these factors together to create one diagnosis versus another.
Do you foresee any sort of? I was just going to say, do you foresee any sort of future where, sort of like we do pre-cognitive testing before sports, sort of at the beginning of a sports career and before a deployment, so that way you have a baseline to compare post-injury cognitive assessment to? Could you foresee a future where we have baseline genetic profiles that predict the risk of injury leading to more chronic cognitive impairment, and basically providing athletes with a pre-injury risk profile of, hey, you can participate in this contact sport, but you're at a significantly greater likelihood of developing trauma-related cognitive deficits than someone without X, Y, and Z genetics? I mean, or is this like pie in the sky for this kind of thing?
No, I mean, I think genetics is coming more and more into so much of the information that people have access to. So for sure, I could see someone getting a genetic profile and have that play into their decision making. Again, from a psychological point of view, which is my bias, would that really change the trajectory of someone who has decided to go into professional football playing? So if you were to tell, I don't know, Tom Brady that, look, he has this high level of the APOE factor, and that's going to contribute to more vulnerability to CTE down the line, would that have stopped his behavior? And I think
you're telling me that if we had genetically profiled Tom Brady, we may have never had to deal with him in the playoffs these last 15 years if he decided not to play?
I'm saying the opposite. I'm saying we'd still be dealing with him. He just would have taken the risk, right? I mean, so, a lot of this genetic profiling, while it might be useful for decision making, might not particularly change one's trajectory. And that's where we get into free will, and do people really have free will if that's what their destiny takes them, no matter how much information they have. It's really hard to know. The other thing is look, epigenetics, right? So even if you have that genetic profile, let's say there's protective factors, he's on a vegan diet and he's exercising all the time. Does that then mitigate the risk? I mean, I don't know that we know one way or another. And that's why I think a lot of these projections about who's going to get what and calling a person as having a certain diagnosis it can be ambiguous because there's so many factors.
We have a question in the chat from your digital media guy. He says, do children have a higher risk of developing CTE, especially since they start playing contact sports younger? I mean,
yeah, it's a good question, and certainly for parents, it's a great question. I mean, there's some literature just that there's almost a window at which children, they're not immune, but they have more resilience to brain injury. So apparently some of the literature points to toddlers, infants that get brain injured, it really does alter their developmental trajectory. But if you're between, let's say, 10 and 15, there's a lot more developmental plasticity where an individual can recover. I think for the individual who has repeated injuries, who starts training for a football career, let's say in their teen years, and sustains these mild TBIs many times until they reach professional level, you might be looking at a different picture in terms of long-term risk. There's second impact syndrome. And certainly for people who are really integrated into a sports field, if they're not fully recovered from brain injury and they go right back in, there is certainly evidence to suggest that they're more vulnerable for a more significant brain injury, even with the same amount of force.
Yeah.
So,
big emphasis of focus with the recent revisions of the NFL's concussion protocol and Tua Tagovailoa's injury. He basically had a bad concussion with motor deficits and somehow cleared the concussion protocol and ended up in the game the next week when he really should have been held out, and then suffered a secondary injury the following week that basically rendered him significant loss of consciousness, possible cerebral posturing. It's a very severe injury, which led to further revision of the NFL's concussion protocol. That was a big focus of our live stream broadcast about 2 weeks ago.
Right. So, I would say, if there's evidence, physiological evidence to back something up, it's this idea of just having a more vulnerable brain right after a brain injury, such that another brain injury, a short period of time, is really going to impact functioning. I think we have more trouble really characterizing long-term, like what happens in 10 years, what happens as the individuals become geriatric. Because again, we have so many genetic codes to dictate that it's just so hard to know what's causing what's going to bring out the manifestation of something. To really all attribute it to head injury, I think, is dealing with a simplistic way of looking at what happens as someone ages.
So I thought of this very interesting point that we talked about with my buddy Mike, who, just for anybody in the audience who was not here for the episode last week, where Mike, a buddy of mine, I deployed to Afghanistan with, suffered a blast injury. One of the things we talked about is the mentality of, you are a warrior who does not want to be taken out of the game. You don't want to be taken out of the fight. And that overlays, I think, a lot with what the NFL struggles with, in that players who need to be pulled out of a game because of an injury, right? The player is not self-advocating. They want to be in the game. They don't want to be detached from their team, from their unit. And they want to be a part. They want to stay in the fight, even if they are not fit to be in the fight. And it's really the military members, athletes, they rely on the oversight of people around them to take them out of the fight, because they're dogs. They're bulldogs that will fight until their body gives up on them. What are your thoughts on that, as somebody who thinks about patients in a very holistic, all-encompassing type of framework? How do you approach someone with that type of injury and prevent them from getting that secondary injury?
Yeah, it's interesting, because so much of the time I'm dealing with the flip side of that, which is individuals who really, in some ways, are very resistant and reluctant to get back into the game of life, so to speak. So, we're really dealing with how to create a roadmap that's gradual and tolerable for the individual, because that's life. They need to get back into life. I think for the individuals who, like you said, are really in a field where their physical functioning and their physical presence is so important, they're psychologically attached to that. You're really dealing with sort of a fine line of awareness of the fact that, look, there's vulnerability, they're at risk. And the idea that, look, the risks inherent in what they're doing could actually create further decrements to their health. And so that's a very specific circumstance in which I think having protocols that you don't leave the decision-making up to the individual are so important. Because I can imagine someone in a military situation, a football situation, they're not going to consider their own best interest.
Yeah.
You know, it's groupthink at that point. So it's really up to these organizational systems to make that decision for them, to say, look, you're still a part of our team, but according to the physiological basis of what just happened to you, you need 6 months where you're not engaged in this risk of another head injury. And again, I'm dealing with the flip side where there is no risky kind of inherent vocational behavior. And there's no system that tells them when and if they're ready to go back. And so it's up to us as neuropsychologists to create that roadmap in the opposite direction. It's time to start trying to get back, as opposed to where you're thinking of in the military and football, where it's up to the institution to say, we have a protocol in place. It's not up to you. Here's how we're going to do it for your best interests.
Now, I want to share the story that you shared with me the other night about, in the rare circumstance, kind of getting back to CTE, in that rare clinical circumstance where you really think you've got the CTE picture. What does that look like? And, in your case, how did you work with this patient?
So, yeah. And again, it's rare because this was not a neurosurgical patient, which is often who we see. At Cornell, there's a memory disorders clinic, and sometimes those individuals will get filtered down to us just because of availability. And this was a guy who was in his early 60s, a high-functioning lawyer who really started to have trouble at work because of memory, short-term memory issues, to the point where he just literally could not function as that anymore. The wife noticed, it was brought to our attention. And I would say, basically, again, just putting together his history, not that there was any biometric to this, but because his scan was basically, for the most part, showed a little bit of atrophy, but that's about it. Really just putting together the fact that he had played college football at a pretty, I don't know what you call them, division, whatever, it's like a pretty high division college, and had played high school football in preparation for that. So had many, many years of these mild traumatic brain injuries, one after another. And here he is at our office in his early 60s, really having significant functional memory issues and showing that on testing. And so, we're going to jump to the conclusion that likely, it certainly could be a rule out for an early variant of Alzheimer's disease, or you take into consideration that all those hits to the head put him to where he is now. Now, again, this is so anecdotal, but given that there's probably many, many individuals who played college football and who have cognitive issues, but they're not being brought to our attention, we don't know just statistically that this person had CTE definitively. What we do know that he had an unusual presentation, just given his age, given the profound impact on his functioning, and given his history. So I would say, if I were going to say, have I ever with CTE, I would point to him. But again, the ambiguity of the diagnosis, the idea that, in terms of neurological treatment, do you give him cholinesterase inhibitor and see how he does? Do you work on memory strategies, which we did? All of that just to enhance this man's functioning, independent of diagnosis, is where to go. So we ended up having him really utilize a memory notebook on a consistent basis. He still very much wanted to engage in something meaningful. So rather than being a lawyer, we turned around to other options. He started to volunteer with young kids, both with reading and sports-related activities. And we helped him live his life with this very significant memory limitation. Will we ever know definitively what his diagnosis is? I don't think so. But it's really, again, from a neuropsych point of view, it's about helping individuals live and function.
Wow, it's an incredible story, and I think really accurately paints the picture of what a neuropsychologist does to help patients. And I've learned a lot about your clinical profession. I've learned a lot about how I, as a medical doctor, can work better with people in your profession to help patients. You know, in many ways, I don't think people who are not physicians realize this, but honestly, probably half the battle of many issues in healthcare is not knowing the right person to send someone to. And a lot of professional networking in medicine misses the opportunity to learn about new places you can actually, or new specialists to send your patients to. You sort of get siloed into whatever your institution happens to offer. And that's where, when you get the perspective of people outside of, you know, your silo, you know, you're like, oh, I can think of patients that, you know, could benefit from that. So I just want to extend my absolute thanks to you, Dr. Sachs, for joining me today. This has been an absolute pleasure. I want to give anybody in the chat an opportunity to post questions, comments for Dr. Sachs before we wrap up for the day. While we wait on any last-minute burning questions to come in, I'm going to go ahead and just sort of start winding things down. We have episodes scheduled next week for Tuesday. We will not be live on Thursday for Thanksgiving. We'll enjoy the holiday, spend time with your family, your loved ones. We will not be streaming on Thursday. We have an exciting episode planned for Tuesday with my good friend Lewis. Lewis is a 20-year retiree of the United States Marine Corps. He has multiple combat deployments and has had both some serious, entertaining, and questionable experiences with the VA healthcare system, and sort of his battling through, you know, TBI and PTSD and, you know, brain-related issues with the VA system. So on Tuesday, you're going to hear all kinds of funny stories from Lewis, because he might be one of the most dynamic and hilarious people I've ever had the pleasure of being friends with. And he's going to bring that unique perspective of, you know, kind of talking about the VA healthcare system, which is, you know, I think it's an issue that is no surprise to many people. But if you're not a veteran who has to deal with the VA healthcare system, you might not really understand what that looks like. And so let's go ahead and throw a question out there from John Kelly in the chat. He said, are stem cells used to treat CTE? I don't believe stem cells are being used in any meaningful clinical treatment at the moment. Obviously, it's a huge emphasis on a research front that has clinical, like, trials. Like, we've trialed stem cell. I don't think, and perhaps I'm wrong here. I very well may be wrong here. I just can't think of an example in which we routinely use a form of stem cell treatment in clinical medicine at the moment. Like standard of care level, not as in usually mostly everything is actually, well, yeah, no, I don't know. Maybe like bone marrow transplants or something like that would fall in that category. But you have any comments on that, Dr. Sachs?
I mean, to my knowledge, I don't think so. But if it ever was, likely it's going to be something that's applicable to a lot of other neurodegenerative conditions like Alzheimer's disease. So to my knowledge, I don't know of that.
Yeah, I read an interesting paper about sort of the overview frontiers of stem cells in primarily neurodegenerative diseases like Parkinson's disease. I think it was published in the Journal of Neurosurgery last year, I want to say, about this time frame. It kind of honestly painted a little bit of like a bleak picture of like, man, things really kind of didn't pan out with stem cells like we were optimistic they would. But in terms of like neurologic treatments, I don't think there's any standard of care stem cell interventions that I'm aware of. I could be wrong, though. I don't know everything. I'm an enthusiast, not an expert. So Thanks for the question, John. We appreciate it. All right. So another couple minutes for questions to trickle in while we wait on those. Again, join us Tuesday next week, the same time, 12 noon with Lewis. We're going to talk about PTSD and the VA healthcare system. Is it failing, or is it just a really slow healthcare system? Albeit, I will say a healthcare system that is slow and possibly failing is still better than no healthcare system at all, for what it's worth. We'll get into it in the nitty gritty next week. So let's see what else. We have shows planned through the rest of the year. December, we'll be back to Tuesday, Thursday. We'll end the year with the Tuesday, December 20th show. And then we'll take a break for the holidays, and we'll see you back in January. So that gives you a little bit of a look ahead for the rest of the year. We thank you so much for tuning in with us today. Before you go, I just have to ask one more time. If you're not subscribed already, please head over to our YouTube channel and hit that subscribe button. We are so close to 10,000 subscribers. And if you are really enthusiastic about what we're doing and you want to support all the things that Brain and Spine Group does with your subscription, you can go ahead and become a super subscriber. For $4.99 a month, you can join our YouTube community. And what that does is it empowers us to keep our technology and our infrastructure and everything that we need to make sure the live broadcasts happen, to make sure that the seminars keep happening, to make sure that we are able to fund student research groups that produce meaningful research that moves brain and spine healthcare forward. It means that we can fund activities that empower patients and families of patients suffering from brain and spine disease or injury. We have a special passion for engaging with the veteran community. Many of them are my brothers, and you're going to see a lot of that new and exciting activities coming from Brain and Spine Group as we turn the corner into 2023. We hope that you'll stay with us for this journey, and that you'll become a supporter. www.brainandspinegroup.org/support if you want to donate directly. If you're a big fan of the YouTube channel specifically, join our community. And you can do that right on our page. Thank you so much. This is the end of today's broadcast of Brain and Spine Group Live. If there are no more questions, we're going to go ahead and take it offline. So thank you very much. We'll see you all Tuesday next week at noon.